Welcome, everybody. And if you can put your name and organization in the chat box, then folks who are taking minutes will be much happier with you. They've been known to take revenge, and if you don't put your name in, they'll just give you random things in the minutes that you will have said. No, they don't, but they should. Okay, so welcome everybody. And we have action items and the consent agenda. Oh, is there any public comment? Karen Turner, you are probably the only member of the public we have here. So you want to introduce yourself, Karen, and why you're here?
Sure. Thank you so much, Rick. Good to see you. I'm Karen Turner. I'm with the Express Specialized Recruiting Group, and we have been engaged by the board and the search committee to conduct the hunt for the next executive director for Central Oregon Health Council. And thought by joining today, I would get some really good insight to continue to sell the organization as we've had the opportunity in the past. So thanks for letting me join.
Thank you for coming. That's very cool that you've come to visit us. It is a unicorn position for sure.
Yes.
Any other public comment? Okay, great. Action items and consent. If people can review the consent agenda and action items. Is there a motion from the board to accept and approve the action item and consent agendas?
I move adoption of the minutes as presented.
Second.
Okay, approved and second. All in favor, say aye or raise your hand or otherwise acknowledge.
Aye.
Okay. Those opposed? Passes unanimously. So Donna Mills, Brad hasn't joined us yet, and I'm probably moving fast. I'm sure Brad will show up. Do you want to just circle back?
Yeah, that would be fine. He was asking for the board packet, so I know he was going to join. So yeah, why don't we circle back? Are you good with that?
Yep.
Okay. All right. And watching just in the last few minutes, right? Okay.
So
All right.
then the next thing, turn it over to Donna, would be the board officers slate.
So what an interesting time we had this year. And, it was very, very close, as you all know, right down to the 11th hour. So without further ado, I would ask Rebecca to please display your slate of officers. And so Rick, are you jumping for joy here or what?
Go ahead and start those monthly payments, Rick.
Anytime, right? So the nominations and the vote did take place via email. So we will need a ratification of the email vote from the board, Rick. And so that's your chair being Tammy Bainey and Vice Chair Linda Johnson for 2022, and congratulations.
Yay. Sorry. I'll try to look downhearted. Can I get a motion from the board to accept the board officer slate?
So moved, Rick.
Second.
Okay, all in favor, say aye.
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 Rick, that's not a reflection of my enthusiasm for you vacating the chair position. Just for the record, or not for the record.
Okay.
And
So
I
I
do
got
hope you
two
won't-
people said aye. That's great. So,
I hope you won't be blocking my number because as you know, this is a group effort in leading this organization. And so there's.
I hadn't thought of
yeah,
that. I
not
got my
funny.
phone here already. I'll block it for sure.
Not funny.
Well, you know, I am one of those more high maintenance employees, so there you go.
Okay, good. So that turnover will happen with the next meeting. So then what we wanted to do was give a little discussion about board hydraulics. And this has been a discussion going on. And I have a few things I wanted to say because I've heard discussions, comments that that as I thought about them, reflected on them, I thought they were really missing some important pieces of how the board works. And so Donna, I just want to say a few things and then I'm going to turn it over to you. So I think the two critical things I think that are important about this board is that it's not a normal nonprofit board that you know, like United Way would particularly approve of. This is not organized like that. It is more of a hybrid model of what would be a normal nonprofit board and what is economists call a common pool resource governance. So in many ways, many of the people involved on this board represent a constituent that has some ownership over the CCO within this community, and that's how we've constructed it. And so because this is a common resource pool that that we're trying to manage. So certainly Pacific Source as part of that ownership pool, but also the community in general. And they're represented by the 3 elected officials on the board. The hospital is part of that ownership pool. Medical practitioners are part of the resource pool. The FQHC, when we designed this, we called them out in particular. Consumers of services are part of the common resource pool ownership. Behavioral health services are part of that too. So there's lots and lots of people on this board with built-in conflicts of interest that you would not have on a normal nonprofit board. And that's by design. Okay, that's what you have in many ways, like an irrigation district. So it's somewhat like that. It has elements of it. Then what we've also learned over many years, often painfully, is that we have a distributed decision-making model. And so what we learned the hard way is that the centralized board is rarely the best decision maker in a lot of decisions that need to be made. So decisions are distributed with the ops committee really dealing with the nitty gritty of hitting QIM metrics, the CAC trying to represent patient interests. There's a contract group that Pacific Source leads that negotiates the contract in a common way. And out of that is a contract metrics committee, also led by Pacific Source, but in a very collaborative way. There's the RIP committees that control the grant making process. And there's Central Oregon Health Council. So and their staff. And so there's all these people making decisions. And part of the role of the board is to make sure that that distributed decision-making process is occurring in the way that we designed, and not to make all those decisions ourselves. Right? So, if I get to say these things and people might be pissed at me, but it doesn't matter because I'm not the chair anymore, or won't be. But I think those things really need to be taken into account as we think about the functioning of this board. And I think the board actually functions far better than has been given credit in our last few months of discussion. And I think, in fact, in many ways that we're a model for the state. But you have to really take into account a model for what? This is not your classic nonprofit board. This looks different, and we've designed it in that way in very specific ways. Donna, you want to say anything else?
Well, Rick stole my presentation, clearly got right into my email. But I would just be remiss if I didn't put up the pretty picture that Camille and I say Camille and I, so lots of Camille, little bit of Donna. Donna doesn't work in these pretty little diagrams, but what I just want to add to Rick said, and Rick, you actually laid it out very beautifully, but really wanting to make sure that the board understood around this distributed leadership model. I'll kind of just put a bow on what you said, Rick, was that, the board operates under the 3 pillars of the strategic plan, which are governance of the CCO, long-term systemic change, and the RAW and the RIP. And exactly what Rick said is that all of those things in their function and their operation and the decision-making, the board has empowered the rest of those little circles and ovals and so forth to do the work of the Health Council from the community perspective by design, so that we really depicted that, the board really follows the distributive leadership model and functions as the Health Council in the boardroom. You have your staff, who is the council at work. And then you have the community, which is actually the Health Council. They're the ones that make all the decisions that drive those things. And the board of directors operates really as that oversight. But probably as I think about in each one of those pillars where the board is very active and represents the work that should be done at the board level, is that you can't escape, and nor should you, the governance of the CCO. That is primarily a responsibility that we have in legislation, right? That's who makes us who we are. It's the tag in the back of our shirt. And then the long-term systemic change, those are the things, the fun and hard things that need to be discussed at the board about how we're going to change things. And those things should really come up through ops, right? And come up through your different committees and different councils to say, gosh, we've hit a real rough spot and we don't know how to move this, or could you please move it? And I think the board is moving more a little bit in that direction now that we are partnering with the CAC about really bringing the consumer voice and how we can meet our customers' needs, if you will, that come up through the Community Advisory Council. And then the RAW and the RIP, I know it only happens every 4 and now every 5 years, but what a huge lift this is for the board and the CAC and the community to do. It takes us nearly 2 years to get ready for that meeting, of which you all put everything you have into creating what those pillars are going to be in the Regional Health Improvement Plan. So I just wanted to reiterate that if you look at Section 2 of our bylaws, it will tell you what the board's duties are, and they are really being able to wrap their arms around the rest of these folks and community that you have empowered to really get the job done, and really look at that hard stuff. And just to reiterate something extremely important, we talk about this a lot, even in our councils and committees. We have a conflict of interest design by design. If we don't have a conflict of interest, we're not doing our job. We're not doing our work, right? And what benefits me is going to benefit you. And you've often heard me say, sometimes you're the windshield, sometimes you're the bug, but we're all in this together, right? So, Rick, I think you really captured that beautifully. And I should have put up your little diagram here before you started so that we could support you with that. So that's all I have.
Okay, so any comments or thoughts about what Donna and I just said?
Is it true? Do I see some nodding heads, especially by those that have been around for a while?
Dan, did you want to say something?
I just go off mute when I think, in case I know. I appreciate that. I think it's just good to be reminded, right? When you, in some level, when you've seen one model, you've seen one model in healthcare, you've seen one market, you've seen one market. And so I think it's good to be reminded. It's easy to kind of slip into a conversation, I guess, maybe as we did in executive session a month or two ago, kind of a little bit of this angst around what are we supposed to be doing? And are we actually doing those things? And do we have clarity on what we're doing? And so, I think we have just enough turnover and just enough complexity and maybe just enough people who have a couple months in between attending meetings and come back in, lacking some of the context. So I appreciate the reminder. This is that chart that you just put up, Donna. For me, the best example is that's why we don't talk about a single QIM getting off track at the board level. And I know that sometimes we question, well, why aren't we doing that? Does that mean we're not being effective? No, it means that's happening at ops, and that's happening in the QIM subcommittee of ops, and it's being attended to in a rigorous way. And if it needed to come here, we have a pathway to do that, right? But there's a reason why they typically don't. So, and I just think that's good governance to make sure that we're spending our time on the clarified things to carry out our duties and our strategic plan. So appreciate the reminder.
And to that point, that Dan makes about it being a good reminder, hopefully you'll send us a copy of that as a continuous reminder that I can pull up for every board meeting.
Of course, Gary.
One thing that I find helpful too, that I feel like over time we struggle with a little bit, is our role with the CCO and the governance of the CCO, but then the broader role with health improvement across the region that is beyond the CCO. So I think the diagram, with those three pillars and then sort of the functional structure to help support all of those pillars is really helpful. And I would almost recommend actually putting it in the board packet every month, because I do think visual management can be really helpful. And then we could just sort of center on like all of those pillars along with that structure. So in addition to sending it out, maybe we could have it be a standing item in the packet.
Okay. Any other comments?
And Rick, this is unrelated to the conflict resolution topic.
Yeah, that's just going to
Okay.
be the next one.
Okay.
Okay. Hearing no more. So Linda Johnson, issue resolution process.
Thank you. And thanks to both Rick and Donna and the group. This last 10 minutes of discussion has been a great lead in. Going with the first pillar of governance of the CCO, we have a governance committee. And a part of a good high functioning board is to identify places for self-improvement. And about 3 or 4 months ago, we had a discussion, I think, that everyone was a little uncomfortable with, and it helped us to identify that there is a place when we have a discussion that hasn't been resolved yet. We haven't, as a board, created an effective place for that to happen. If it, as Rick just explained, if it's one, for example, related to QIMs, then we have a committee process for that. But every now and then, certainly several times in the past, but I think going more into the future, we're going to have more situations where as we start to really redesign and redirect the health system, that conflict of interest that each of the members have that have their workplace hat on and their council hat on at the same time, as the temperature heats up and the reality of change starts to hit us, I think it creates a situation where we are more likely, not less likely, to have potential issues come up that we're not able to resolve immediately or through the normal paths. So governance committee talked about this, and we have a proposal that we want to bring to the council for discussion about when those difficult issues crop up. And the other sort of an underlying assumption, which may be a reminder to our commitment, as stated in the bylaws, an underlying key assumption that the governance committee has is that there's an unquestioned commitment by everyone who's on the board, not just to the work of the council, but also to the success of their organizations. It's not either or. And so there's a deep commitment to resolve things in a collaborative process to the greatest extent possible. And with that underlying assumption, the governance committee talked and proposed a model where that could happen. So as we've just heard, anytime there's an issue that erupts or that comes up, QUIMS is a great example where we're not meeting our measures for one or more reasons. If there's an appropriate committee that normally handles that, it would go to that committee for discussion. And 99% of the time it's handled there. And then the board, if it's not resolved there, or even if it is resolved there, if it's significant enough for the entire board to know about it, it comes back to the board in the form of a report. But let's assume that the issue is not resolved at that appropriate committee level. Then at that point, a request can be made by the committee or the committee chair to the board chair. That says we have this issue. We weren't able to resolve it at the local level. We're still committed to resolution together. We need some assistance with it. And at that point, we currently haven't had a place for that to go other than at the board meeting. So what we're proposing is, for now, I'm going to call this the box. It's not an elegant name. We'll have to rename it something. But what we governance committee proposes is that there be a box that the chair can refer that to. And what that means that the people that go into the box would talk about the issue. If it's relevant to a contract measure, then Pacific Source would be involved, and that it would be facilitated by a disinterested party. It could be another board member who's not party to the disagreement, isn't affected one way or another. Or it could be that the board decides to contract with a professional facilitator to help make sure that everyone's best interests are included in that, people listen to each other and are together through that process, like a dispute resolution process, to identify a win-win for everyone. And at that point, the expectation is that the problem would be worked there until it is satisfied, everyone's interest is satisfied. The other way, and then when that happens, whether there's progress or not, there's a report back to the board from someone who has been leading that issue to the box to say, we went in, we talked, we've reached agreement, no need to talk about it, or we've reached agreement, here's a key issue the board needs to know. So there would be that closure of the feedback loop on the process. The other way that issues could be referred is directly by the board chair. If the board chair hears of an issue that's out there, maybe that hasn't gone to committee or comes up in the board process, then that's the other way that it could be referred to the box. Justin, you and I think, who else was at the board? Oh, Paul, were at the governance committee meeting. Did I miss anything, or do you guys want to add any comments, or Donna, on the model as I've shared it?
Not me personally. I think you captured what we discussed. A way to get a resolution, a guarantee resolution.
Agreed.
Agreed.
So at this point, we'd just like to open it up to the entire board for your reactions, refinement, improvements, and see if this seems like a good process for the board to go through to resolve those intractable issues that are new or that continue to persist.
Linda, this is Megan.
Uh-huh.
I think it was really helpful actually to have that diagram prior to this presentation. And what that made me think about is in the first part about issue identified, it almost might be helpful to think about where is the scope of work related to the issue? Is it a RIP issue? Is it a governance issue? And make sure that the right kind of first resolution step occurs. And that if it's not resolvable with the right scope of the body, then it can get escalated through that structure that Donna showed. And one of the curiosities I have is, as far as issues that are raised, did you guys talk about, are they issues that are within the scope of the Health Council or Health Council structure? Or is it issues that are beyond that Health Council members wrestle with that are unrelated to the scope of the Health Council?
That's a great question, Megan. And I realized I skipped over the, when we find ourselves asking, which is, I've been present for a number of board meetings, is this really our scope? It's the board's responsibility, I think, to determine, is this issue one that is pertaining to the scope of work as defined by our bylaws and our mission statement? And if yes, and assuming there's a committee to refer it to, that would be the first step. If there's not a committee to refer it to, then that's good governance would say, okay, is this one that is a unique situation that goes into the governance box, or is there a need for us to create a committee because we see a whole bunch of these issues coming down? So that determination, once it's in the scope, the second question would be, do we have the capacity to deal with it? Great question. Did I answer your question? My thoughts about it?
Yeah, I think that's really helpful. And I think the other, maybe role the Health Council could play is if it's not within scope to kind of redirect folks back to the other channels of communication and conflict resolution that are available to them.
I'm sorry, I'm having trouble hearing you, Megan.
I'm sorry, this is my computer. I said the other role maybe from a Health Council, if it's not within scope, is to help route folks back to other pathways and other structures to help with that conflict resolution.
Right.
I think the other thing is our hats, like Rick, you called out, we have, lots of different roles. And when we're on the Health Council board, we have our Health Council board hat. Mm-hmm. But then sometimes I think we're doing presentations or talking about things and we might have our other hat on. So I think just hat clarity in what role we're playing in the different conversations, I think would be another best practice for us from a governance perspective.
Mm-hmm.
Hi, this is Brad. Can you hear me?
Mm-hmm.
Yeah, I've been having a lot of connectivity issues, so hopefully I'll stay connected. I have a couple comments, questions. One for Linda, is this, the Community Advisory Council recently developed an emerging issues, as you know, Linda, an emerging issues process. I'm just wondering, are you utilizing that? Because I'm not sure why they would need to be different. Or if they do need to be different, it seems like you'd be able to use most of what we created for the Community Advisory Council and just adapt it for the board.
The community advisor or the CAC issue identification process, as I recall, is to assist when we get reports from the community about a particular issue that our clients are facing. What is a big issue versus what is like an emerging issue that we need to bring to the board versus a once-off. And so that process helps to clarify and vet and ask the questions, who's dealing with this, who's the appropriate handoff, and to get that feedback. This is really more, not as I'm envisioning it, it's really creation of a problem resolution process at the board level when we don't have a governing structure that facilitates a safe conversation about the topic. It's not focused on the topic itself. It's focused more on what systems and processes do we have in place to resolve the unresolved issue as it comes up. So that's how I see them, as a little different.
Okay, okay. My other question is there a role for the CAC in this process?
That's a great question. I'd love to hear thoughts about that.
And specifically in the issue resolution process of the board, is there a role for the CAC to play?
You know, if I might, my immediate thought about that is yes, but it would be one of those evaluating what it is and whether or not it belongs in CAC to be resolved. Being that there's a piece and part of this that really looks at what's the body that should be deciding this. Is there a place? And so we'll just use the QUIM example since we were talking about that. Yep, there's a QUIM work group that's where those things should be resolved. Very rarely would that ever be elevated to the board, and very rarely would I think that we would need to use the process. But I do think that if we go back to the diagram with all the circles, we're gonna be looking within our circles in community to resolve things and in anything and everything that we can. And the board is really that's kind of the last stop, right? We would hope CAC is one of those circles that we would be able to resolve community issues within the community leadership structure. Does that help, Brad?
Kind of. I guess I'm just trying to get clarity. So is this issue resolution process that we're looking at right now, is this more of like a conflict resolution process for the board? Or are we talking about actual health system issue resolution?
It's more focused on the organizations that the board members represent. But it could be that a part of the issue resolution is a shift in how services are provided. And in that case, I think CAC definitely has a role. But if it's really how can the board members and the organizations they represent work productively together, if it doesn't impact patient care, I'm not sure that that's directly of interest to CAC. It's only when it starts to impact how they receive care and how they interact with the system that CAC would have a role, I would think.
Okay.
Other thoughts or questions? These are great.
The only other thought I had to Brad's question and Donna's response is in looking at the flow chart here, it could be that in a rare situation, it could be referred to the appropriate committee, and that appropriate committee is CAC. The other thing is if there isn't an appropriate committee and there is the box that is initiated by the board chair, that again, under participants, asking the question whether CAC members might be appropriate participants is another place to be looking. And should we be hearing the voice of folks who are most impacted by the decisions? And so I think that's the other place that CAC could have a role in this as well.
And I'd just like to add on, Linda, when we had the conversations, I really want to make sure that the point of the dispute mechanism is not a way to, just take it off of the public forum and to take it into a place where it can kind of set without the daylight. Ultimately, though, I think one of the things we talked about is it very much requires a set of expectations from the board. I mean, as a board member, if we're on our way to missing providing quality care to recipients of the program, I don't want to know about that a month before. I don't want to know that the CAC couldn't find a resolution a month before the end of the year. I think so that really requires from us the expectation that, on issues that require quality and healthcare performance, the board should be updated with people or groups that need additional improvement if they're not making it routinely. We shouldn't get to the end of the year and have to rely on the state changing the targets for us to get there. I mean, one way or the other, if we thought that the target was a good target and a good measure, and it's care that should be delivered to patients, we should have a problem with the thousands of patients who didn't get it, even though the target changed.
So Justin, unfortunately, you missed a presentation that I was trying to level set about the function of the board and a distributed decision-making process that we have here. And so we do have, in that discussion, I said a couple of things. One is that this is not a normal nonprofit board. It's a hybrid between a common resource pool governance and a nonprofit board. Two, we've learned painfully through many years that it is wiser to have a distributed decision-making process. And so and basically the observation is when we didn't do this well, let's just take, for instance, the QIMs, that most people in this room are only vaguely aware of all the details that go into meeting a QIM. But we do have an ops committee that is meeting quite a bit with content experts trying to hit those QIMs. And they have a mechanism through the chairs that when they hit a roadblock that they think would be useful to bring back to the board to resolve, they have that mechanism that they can do that. Same with all the other committees that are here. If they, for instance, we used to approve all the grants. And we found that we were really quite poor at deciding the grant, making decisions around the grants. And so we distributed that decision-making out to the work groups. So in many ways, the primary role of the board is to make sure that this distributed decision-making process is actually happening. As opposed to putting our finger on every decision within that deal, unless those content experts believe that it would help to bring that decision to the board. So that's a context I tried to lead the meeting with. So
understood. I think there's probably somewhere between we get into a diabetic metric at this group and debate how it's recorded in the medical record and being updated once a year on what we're going to miss. There's probably somewhere in between. But understood, if the point is not to follow the performance of the organization at the board level, unless it raises to crisis level or someone needs to ring the bell for crisis level, that's just a misunderstanding I had. Understood?
Yeah, and so I think we do have reports to the board about the performance of the organization. And that is, so we can, and the point of that was to attempt to have those distributed decision makers coming back to the board about their process and about whether they're hitting their marks or not. And that allows the board to determine, are they doing their piece, or is there a worthwhile intervention by the board to be involved? And again, many people on this board, I've been sitting in the QIM work group since it was founded ages and ages ago. And there are very, very frank discussions within that work group and that's a closed work group to allow those very frank discussions to occur.
And Rick, could I jump in from a governance perspective?
Sure.
If there's a part, and could we switch back to the other graphic that we talked about earlier? So we have a system where the majority of our issues have a place to be vetted and aired and discussed. A part of good governance is having a mechanism for any one of these bubbles, whether it's finance committee or the QIM work group or the health improvement plan work groups. As a participant in any of those groups, if we feel like the group's not functioning in the way that it should, or it's not communicating back to the board as often as it should, it's incumbent upon the member first to bring it to that chair and to air that with the group. I think we're not doing X and I think we should be. Group talks about it. And if that doesn't change things, then that's an issue that does need to be communicated up through the arrows and eventually to the board. If we have a group that has poor leadership, for example, or isn't doing the work that the board asked them to do, it's important for good governance for the board to know if a part of this diagram isn't working, because then the board needs to get in and do some work with that. But the key point is that we do work within this system of committees, and we get feedback if a particular part of the committee isn't working, and it's done through the system. Does that make sense?
Yeah, and then the other thing is, there are quite uncomfortable conversations happening across the system. I'm in the committee that negotiates contracts with the hospital and COIPA and Mosaic and the CMHPs. And that is a very frank discussion led by Peter McGarry, but has representatives for all of you, of the owners, of the providers rather. And those are very frank discussions. Again, very frank discussions in the QIMs. I haven't been part of the CAC, and very detailed discussions in the RIPS. So I just want us to be aware that this broader distributed decision-making process, I think, is actually very important for a community resource like this. So. And then Linda, my one comment is I love the name of the box. It reminds me of Cool Hand Luke. And if there is a inability to communicate, a problem to communicate, you're put in the box. So we have a failure to communicate, and there we go. So, and you'll sweat it out until you solve it. I like that.
It's one of my favorite movies. I was going to call for a name change. Now I'm not so sure I will.
Damn.
Rick, if I could. Yeah,
Sure.
just, speaking to kind of the balance that Justin was speaking to, a lot of us work in organizations and either report to a board or attend board meetings on a regular basis. And I know a lot of boards have standing reports from each of their standing committees at every board meeting. And it's just an opportunity for the chair of the committees to say, here's what's going on, here's what we're tracking, here's what's red, yellow, and green, here's what I need you to be aware of. And in some cases, here's maybe some action that the board might need to consider taking. And I would just offer that as a best practice. I know that happens in our organization quite effectively. And then each chair of the committees knows that at each board meeting, they're called upon to give a brief report. And that's, we could say, hey, it's in the consent agenda, and maybe that's worth a quick debate here. If it's in the consent agenda, is it attended to as much as it is if it's a brief standing report? So just a thought.
I would encourage a brief standing, as your outgoing chair. I get to say all sorts of things, but I would encourage Dan's suggestion, because I think that can do two things. One is it improves communication back and forth between this distributed decision-making structure that we have in the central board. And then two, it also reminds the central board about the distributed decision-making process. So take note, Tammy, next month you can say, that was just crazy, Rick. Any other comments or suggestions?
Rick, it's Commissioner Dare. I have a question for you.
Sure.
You had said we used to approve the grants, but we were quite poor at doing that. Do you mean we spent too much money, or we weren't educated enough to be making that decision?
The second is the process is that we didn't understand. We would have, we would be sold with, the proposal that would be presented before us, but would not have a broader picture of what was possible, what was needed, what was driving us to, what would help us drive and to meet certain metrics. And so literally who had cute babies, I learned that in making some of those grants, always stick cute babies in front, and that helped you win that proposal. But
I really appreciate the grant that was made to the Stabilization Center, and it is being used by Central Oregon. And so, I appreciate what happened with that grant. So
right.
Anyway.
And I'm certainly a recipient of one of those grants, and I'm happy with that too, but with my other hat on. But what we wanted to do was drive that decision-making closer to the ground with those area topic experts in the areas where we were working on the RIP. And so that was where we've moved that so that we hope that decision-making happening at that level can help drive meeting those RIP goals, which we've already designed in our process to be aligned with the broader goals of the CCO.
And Rick, if I can chime in here, the beauty of the RIP process is that we have a room with our community partners of content experts. And at the board level, we may or may not have a content expert on a particular grant. And I recall that some of those grants I could be quite excited about, but there were more questions because of what we didn't know in the process of approval. And it took a huge amount of time. And it was another one of those issues of, is this really our role as a board? Or should we create a more qualified and competent way of making decisions that we still oversee and are accountable for? But it's more informed and allows a more careful consideration of the grant requests. And at that point, we shifted it to the RIP groups.
Okay.
And they're brutal, by the way.
Yeah.
They have some rigor in their decision process.
Okay. Any more discussions about Cool Hand Luke in the sweatbox?
Do we need to ask for board approval of this structure?
Sure. How would you like that motion constructed, Linda?
How about a motion to approve the proposed joint resolution process? What did I call it? Joint issue resolution process.
So moved.
Okay, we have a motion. Do I have a second?
I'll say it.
Okay, we have a motion and a second. Well, we've discussed this to death. So all in favor, indicate yes in some manner. Okay. Those opposed, please indicate such.
And I want to say thank you on behalf of the governance committee and for the governance committee. I appreciate your involvement in the process and just the opportunity to look at who we are, how we're doing it, and to move forward with a way of improvement for all of us. Thank you.
Okay.
This might be just a suggestion for staff, but when you have like structures or agreements like this, as you bring on new board members, it might be good to put it in the packet along with the bylaws and just kind of the overall orientation to the Central Oregon Health Council Board, just so that if you want it to be kept alive and kind of utilized and a part of how we organize ourselves, it would be helpful.
Got it. Thanks, Aman.
Okay, and hey, talk about distributed decision-making processes. The next one is the Finance Committee. Megan Hayes, please report on the uncomfortable conversations we had in the Finance Committee.
Hey, well, we're at the time of year that we're working on the CCO budget. So the process of the budget is our Finance Committee works with the Pacific Source team, starts a couple months back looking at some assumptions that the team will use to put into the budget. And then they come with a budget to the Finance Committee in the hopes of approval to be recommended to the COHC board. And then the timing of that is such that the ideal is it happens before the process with the Pacific Source parent board. The last few years, when we've approved a budget, or last 2 years, the budget presented to the COHC recommended by the Finance Committee had a less than 2% margin, which if the budget performed at that level would trigger through the JMA a future recapture of shared savings from the Health Council. And the last 2 years we had good discussion about that approach at the Finance Committee as well as at the board, and we did approve both of those prior year budgets. The budget that came to the Finance Committee this cycle also had a delta between the 2% margin, and there was what Rick said, a good robust discussion about the interest of the committee to have that margin closed, so that what would be presented to the full board would be a budget that had a 2% margin. So there wouldn't be a potential recapture with achieving the budget. And there was a lot of good discussion about what are mechanisms and ways that realistically that could be put into the budget, with an ask for Justin and the team to come back with those options in there, which would close that 2% margin. And so we do not have a budget proposal for the Health Council today. That work is going to come back to the next Finance Committee with a hope to bring to the full board after that meeting. What is going to happen is in the interim, the Pacific Source Board is going to go through their Finance Committee and their board approval process as well. We did talk with Justin and team about bringing the conversation at the Health Council to the Pacific Source Finance Committee and board as well. Another aha during the committee meeting is that while the CCO budget process is happening, there is also a contract committee process occurring that is determining the CCO contract with providers and the community health, mental health providers and hospital COIPA. That timing historically and with this current year tends to go longer than the timing of the budget approval. So there was some interest at the Finance Committee if we could, if the contract committee could consider a process that allowed the timing of that to come to a close so that the CCO Pacific Source team would have that information solidified as they bring a budget to be approved. But the timing is quite off. So the budgeting happens with some assumptions about where that group will land. So anything to add, fellow Finance Committee members, or Justin or Leslie, Tricia, Aaron?
I think the only thing I would add is I agree it was a good conversation, and I think both sides came back with a stronger understanding of the desires on both ends and approaches that may differ. And I think, as Megan mentioned, you know, from a Pacific Source side, we're going back and looking through the numbers, and we'll present some options at the next Finance Committee with the hopes of obviously getting to a resolution that doesn't require us going to the box, maybe, and then taking this back to you guys here in the January meeting and getting approval. So.
What questions does the full board have, or any advice or recommendations back to the finance?
So questions from the board? Advice? Do you agree with our approach? Do you think we're ridiculous and need to take a different approach? Or because the Finance Committee is a representative of the full committee. It's an animal of the full committee. So this is advice and consent for the strategy.
I respect the recommendation of the Finance Committee, and let's see where that takes us.
Thank you.
Okay. So wisely, Paul will speak for everybody. That's usually the best approach. That's been my experience. So we'll go with that. Thank you. Then, Megan, did you want to discuss further about implications of future recapture?
Yes, I think the other topic that's come up at the Finance Committee is that the recapture. So we, had a recapture last year. Pacific Source graciously waived that. As you guys have seen in the packets and Tricia presented on last month, and we've talked about the Finance Committee, we are going to likely have another recapture. The amount, I think, Tricia, when you reported last month was 1.7 million. I think we're up to, Justin, can you remind me of the likely recapture?
We're 3.2 million, and that was reported into the last month's financials.
Okay. So up to 3.2 million.
Correct.
And that was October's financials, just to be clear, not
Correct.
November's.
Yep. And from a Health Council perspective, as we think about the CCO, the waiver where 3% of our budget is being invested into the community, and thinking about those investments in ways to really move the dial on health and well-being. So these buckets are pretty important from a state perspective and a CCO, and I think also are aligned with the work we're doing around our RIP. And so as we are in this environment of recapture that could continue into the future, the bucket that recapture comes out of is future shared savings for the Health Council that are getting invested in these different ways. And so it really was just to raise awareness to that and open up a dialogue or a generative conversation. There isn't an ask for anything, but we really wanted the group to understand that this recapture does come out of these Health Council future dollars that get put into different mechanisms that are in that bubble, with some expectation from the CCO and the state as well. So Donna, do you want to add anything, or anyone from the Finance Committee?
Yeah, I would. Thank you so much, Megan. What I wanted to just mention is that, yes, we can use reserve that we have currently to pay the whole recapture if that in fact is the condition we wind up in. And the JMA is very clear that the recapture can be paid back at a rate that doesn't disturb our business operations at 50% of either our operating income or our RIP. We have our 1% RIP monies that we receive every month. But I think that the point was, and to Megan's point, there's no ask here. This is really about socializing the board to where where we are in this current condition. So we, everyone sees the balance sheet every month and recognizes that we have funding that we have promised to the community, and we keep reserves to make sure we can make those. I know that Pacific Source doesn't want to be in a recapture position either. They want to attain the 2% margin, and we want them to as well. But it's just a matter of really creating an awareness for the board that this isn't the first recapture condition that we've been in. 2020 was a bit of an anomaly at the recapture being calculated at $8 million. But we all know that COVID played a big part in that. And we still are so very grateful that Pacific Source waived that recapture. But here we find ourselves again at the end of 2021 in a recapture position and being presented with a budget for 2022 that right now indicates a recapture situation. So I think it's good policy, right, to be transparent about that. Thanks, Megan.
Could I clarify that, Donna? So just making sure I get it right. So in the contract, if the Health Council spends more than was appropriated to the Health Council, there's a 2% recapture of additional funds that were spent over. Or if the entire contract, if the $300 or so million that's allocated to it, if all of that money is spent and then more, there's a recapture that costs the Health Council. Or am I saying any of that right? Or
so what you're talking about is actually 3 different contracts, right? So there is the contract with OHA and the global budget that happens between Pacific Source and OHA. Then there's a joint management agreement that's just between the Health Council and the CCO with Pacific Source. Then there's a provider contract, right? The provider contract kind of rolls up in that first one I talked about, the global budget. So when the global budget runs through, and I like to call it the pachinko machine, right? We get our 1% off the top, and we also get our 0.325 for operating revenue. It comes right off the top of the global budget. And then all the contracts with the providers and all the claims and the admin fees to Pacific Source. At the end of the day, our contract in the JMA says that the CCO will retain a margin of 2%. If they do not retain that margin of 2%, then that triggers what we call a recapture. And that recapture is from the Health Council.
so is it fair to just say, simplifying that, is it fair to say in the global budget, if we spend everything that's in it, then there's nothing to there is no 2% margin if you spend everything you have, and then that's what triggers the recapture? Is that oversimplifying it?
It might be.
Okay.
If there's not a 2% margin for the CCO, that triggers a recapture with the Health Council.
So, and the only way there
Just
wouldn't
to the
be-
2%, just to the 2% level.
Gotcha. But the only reason there wouldn't be 2% left over is if you spent everything that was allocated to
Clearly,
it.
if the expenses came in for the year and they went over that,
Yes.
a
And
proposed budget,
Is it fair to say that in the global aggregate, the total spend tops $300 million?
yeah, it's a
Okay.
math problem, right? Yeah, it's a math.
Yeah, just in classic sort of insurance CCO financials, right? So if the premiums coming in are outspent by claims expenses and all the other expenses and don't net out to a 2% margin at the CCO level, then there's the recapture. And it's actually pretty interesting because it was an original provision of the JMA, of the first version of the JMA way back when, and has largely remained unchanged. What we've done with shared savings has changed over the years, but the 2% trigger to a recapture hasn't.
So Dan, is it fair to say then that the issue that we're all discussing right now is, for whatever reason, we have not figured out how to deliver care more efficiently, or our service, whatever the service is, even if it isn't care, we haven't figured out how to deliver that in a way that would save at least 2% off the top, and thus the issue we're running through everything that is allocated.
Yeah, the trends in claim expenses, pharmacy expenses, COVID-related expenses, all the coming and going of the insurance, cycle and managing risk.
Yeah.
This year is not projected to perform at a 2% margin level. Exactly.
And then that's projected for the same thing next year.
At this
It didn't happen
point,
in 2020. It's not gonna
yeah,
happen. I got you. Okay.
on the budget that was presented to finance, which, as Justin said, we're going to look at and revise some assumptions. Don't want to get ahead of myself, but likely come back, and because we were pretty close to a 2% margin projection for 2022, we're probably right on that line, Justin,
Okay.
for 2022. But what you said is accurate. Yeah.
So, and just to be clear, the budget is a planning document. And Justin built in some sound and conservative assumptions built into that. And we weren't challenging on the finance committee his assumptions. I think they were good, sound, conservative assumptions. But what we were asking for is what are options to either cut or what are options that he can present to the finance committee and ultimately to the board to make sure that we have that 2% option. And whether that's to go back to the contracts committee and say, hey dudes, you have 0.5% less to play with. That could be on the table.
So I promise, last question, just to understand this, Dan, you were saying, so is it fair to stipulate then over the last 3 years, we haven't delivered care in a mechanism that saved at least 2%? Because the allocation hasn't went down by 6% over the last 3 years, right? Like there hasn't been a 2% cut in the allocation every year for the last 3 years. We simply have not done anything that has delivered a true bend in the total cost of care, because all of the funds are being eaten up or allocated into, like you just said, claims base and everything that's there. Is that fair to say?
What I would say is anybody who wants to learn more about all of the components driving it is completely welcome to, because we're at finance and in other circles, we're more than happy to share all that. Justin, I think that's true, although it would, and I'm not suggesting that you're being too simplistic. I think it's too simplistic just to say we haven't bent the curve enough. I think there's some areas where there's been significant progress. And then as we know, there are always areas that are growing at faster than either rates that were anticipated in year prior. So COVID expenses would be one of those. Pharmacy expenses would be another one of those. So we're constantly making guesses as to what those trends might be. We're also subject to the annual rate setting process at OHA, right, which drives the premium. And we're also subject to when we have changes in membership, as we have, it changes the risk adjusted premium that comes into the seat. So all those things happen.
I'm sorry, I guess my question, sorry, I am trying to oversimplify, but it was just simply the amount allocated every year has not been, like the state didn't cut the program by 6% or something. There wasn't a major change in funding levels that created the gap, the changes in consumption of services, one way or the other, whatever it's for.
Yeah.
Right. I think the hydraulic is one, your point is correct. We haven't been driving efficiencies through the system. Two, I think the impact of COVID and staffing shortages has been profound in the last year, and has really, having sat through many of these committee meetings, really thrown a wrench in all of our attempts to do things, and the CCO has correctly read the environment, and that keeping the healthcare system afloat and operating as best as it can within a fairly unprecedented crisis has been its first priority.
Understood.
But I would agree that efforts to create efficiencies within that system have not succeeded. And it's been an incredibly challenging environment in which to do that in.
So just for clarity, like I was just trying to get to the funding level didn't change.
The funding level has gone up by
Okay.
3%.
So there was more, we've never had more resources than we have today.
Yeah, I don't know about you, but my salary base has gone way more than 3%.
You may not
I don't
have
know,
kept up with
maybe
inflation.
you're able to attract folks at a cheaper rate than everybody else. I don't know.
I got you. I'm just saying in terms of sheer dollars, the rates didn't, there wasn't a big cut.
Yeah. Okay.
Okay, fair enough. I got it. Thank you.
And Donna, is the recapture, was it for 2020, obviously, which was forgiven, likely for 2021? Was there a recapture for 2019? No. So the recapture really has been during this pandemic time, and like Rick, there's certainly efficiencies that we can gain always, but we are in very unprecedented times. So it will be good to study like where are those opportunities and what's a product of the environment or price increases, which probably will be continuing with some of the environment that we're in currently. Any other questions? Thank you, Justin. The Pachinko machine is very complex and hard to keep top of mind. Are there other questions that the group has?
It might be interesting, and we could do this really easily, to produce just sort of the 10-year history of CCO, financial performance. And Justin, we probably have a graph that we don't even need to update. If folks are interested in that, we had a almost an unprecedented run of positive shared savings. That's not to say that we should applaud ourselves for historical performance. We should worry about current and future. But it's interesting to look at that trend in Central Oregon. It's been a good one.
Yeah, I totally agree. I think it's just interesting that I believe what Rick said, the request was any advice. And if I guess my only advice was that I was trying to point out at least that there's an easier way than just cutting reimbursement. If there's more money than there has been in the past, there's probably more opportunity to be more efficient with the way it's utilized. And in the same way, Dan, I'm sure there's spend for COVID that didn't exist in 2019. I would imagine there's probably plenty of spend on surgeries and other items that didn't happen this year. So is there a way to reappropriate funds from where there were surgeries or where there weren't surgeries to where there is COVID, or where there is COVID to, there may be ways to kind of make a few shifts and make it all work out based on the services that were actually utilized, and then maybe set some targets for all of us next year on like, hey, could we deliver care more efficiently and to the 2% tune? I don't know, maybe not, but at least if we had those. So that was all.
And remember, in the contracts committee, Dan once wondered whether I was in every committee that was available, and I am. So in the contracts committee, there is a long page of rates for here's specialists, here's hospital cap, here's fee for service, it's a very complex and detailed structure there for the provider contracts. And those are currently getting debated every Wednesday morning at 7 a.m. And my observation about the healthcare industry is it's highly regulated because of how payment structures are set up. So anyways, these are really good conversations. And then Brad, because I'm running this meeting quick, we had jumped ahead of you. So I want to go back to patient story.
Okay. Thanks. So a member of our Community Advisory Council, Regina Sanchez, who works for Cook County Health Department, submitted this, has shared this. Here we go. One of the challenges we've seen for our WIC, Women and Infant Children participants on Oregon Health Plan, is that they can't get their toddlers in to see the dentist. We've had a client try to get their child seen at Advantage Dental in Prineville. They will not see them. They will not even schedule them that young. If they're not staffed to see children that young, we need to see what we can do to get these children assigned to a pediatric dentist. We also see that parents find it very hard to figure out what provider they're assigned to. I have a client that had been trying to get a referral approved by Oregon Health Plan to get her child in for oral surgery. This child has been in pain for several months. In the meanwhile, when this referral is going back and forth with whatever loops need to be closed or appointments that need to be scheduled, this child's mouth is becoming worse and more painful. We need to see an easier way to get these types of situations handled. It is challenging for us community health workers to navigate these situations for our clients. I can't even imagine someone trying who has no idea where to start.
Brad, can you send that to me again? I think there's some misconceptions in those observations, but it gets difficult to address them in general terms because certainly we see children beginning at 1 year of age. So, you know, I can't imagine where that's coming from, but I'd like to track it down.
Okay, yeah, I'll ask, actually, Michaela, would you send that to Dr. Allen? Where are you? You're here somewhere.
Sure.
Thanks.
One of the things that makes me think about in the dental space is thinking like if you're a patient, there's our CCO and then there's 3 DCOs. And then the DCOs each have their own provider network that they contract that are dental providers. Some have overlap and some don't have overlap. So I'm thinking about the story last week and the story this week. You know, maybe I wonder if there's some difficulty because of some of the structure that can contribute to confusion for families about how to navigate some of these things. That's just, when I've heard both these stories, that's kind of where my head goes. I think there can be some complication there too. It's different from like traditional dental insurance.
Yeah, I would agree with that. And you know, a lot of times they don't even know who their dental provider is because, you know, they know that they're a Pacific Source CCO patient, but it could be one of 3 dental providers. And then from the DCO level, they are assigned well, at least our model is, they are assigned to a particular provider within our network. I believe the others are similar, but it does get difficult. I will certainly attest to that, trying to figure out, okay, who is my provider? Who's my DCO? And then who's my provider? I do appreciate these because it gives me an opportunity, as well as the fact that, you know, we have relations with the other DCOs. So, you know, these sorts of issues that are elevated to the Health Council, you know, it's something that in general terms, without going into the specifics of the issues, we discuss as a dental stakeholder group.
I just wanted to say thank you for bringing that forward, because while we enjoy hearing the stories of where everything is going really well, I think it's really powerful to hear where something is maybe not where we want it to be. So I just wanted to say thank you for bringing that forward. And I think it is a good opportunity for us to reflect on, you know, I'm thinking of myself as a parent with a young child, how many other things might be going on for that parent. And if there are ways in which we can help to streamline the process and use this example as a way to affect change, whether there are some maybe miscommunications or whatnot. I think it gives us all a chance to really embrace and kind of lean into the continuous improvement sort of thinking. So I like the conversation, and I appreciate you bringing that forward, Brad.
Yeah, and on another level, with some of these community access points, we actually do have expanded practice dental hygienists that are embedded in providing services at those sites for the young children too. So not everybody necessarily needs to go in to see a dentist, and a lot of those are screened at the community site level for young children.
I'm curious, how is dental working in other parts of the state? Is there anywhere?
It depends on which
better?
part of the state. If you're talking about the metro area, where we are less affected, particularly, talking about our DCO, but I think I speak for other DCOs as well, where we're less affected by staffing shortages. The staffing shortages that were alluded to earlier in the healthcare industry also are dramatically affecting dental. And we talk about having availability of dentists, but not a lot of attention is paid to the support staff, the dental hygienists, the dental assistants. There's a nationwide shortage of dental assistants, and that makes the dentist work less efficient. It would be like going into an operating room without your full staff and being able or trying to perform a surgical procedure. Dental dentistry is microsurgery basically. So a dentist can only work as efficiently as they have support staff. So that's a long-winded answer to your question, but it really does vary by region of the state.
So just to follow up, so your sense, Dr. Allen, is that it has more to do with staffing capacity than it has to do with the actual system of the DCO or multiple DCOs?
I think it's both. I think what Megan mentioned earlier about the complexity of navigating the healthcare system in general, but then trying to navigate it down to the dental access level and determining who your DCO is, your dental plan that you're assigned to, and then your provider. Although I know all of the DCOs have customer service departments. And on the previous patient story that was brought forward last month that we followed up on, we all have care coordination teams. And a lot of these get handed off to them, and they're kind of handled one-on-one, depending on the complexity of the problem. If it's a situation as we had with the last patient story, where you're kind of navigating through behavioral health and physical health in the case of a lot of them because of medical comorbidities, then we hand those off to our care coordination teams. But we're talking in general. We're talking in individual issues that are being faced and trying to address them with the generalities. We acknowledge the issue with the staffing shortages. We acknowledge the issue of having shortage of particularly dental specialists. That was addressed in the last discussion. The complexity of the problem. So, but I think bringing these to light is helpful again, and allows me to take it back to our team and try to troubleshoot them and figure out what's going on.
And one more follow-up question, if I might. Do you have any idea how well you're doing with non-English speakers? You're serving non-English speakers?
With the who?
Non-English speakers, either Spanish speakers or they speak another language.
We have interpreter services. That's the best way I can answer that in general terms, and that's available to all of our members. So at least from the reports that I see, we're doing well in addressing that.
Okay, because I know
We
that.
certainly have systems in place to address it. Let me put it that way.
Gotcha. Yeah, Regina does, serve our Spanish-speaking community. Not only, but that may be who she's speaking of. I don't know that for sure, but in this patient story, I'm not sure, but it might be. But communication becomes a really critical thing and can easily get, miscommunication can happen easily when there's a language barrier.
Okay, great. Actually, Brad, I just want to thank you for really, I think the movement of having CAC present the patient stories has been useful for us, and really having us squirm. And I feel for Gary because I'm quite aware of my own system could have uncomfortable questions. Well, actually, Brad, I think you've called me up and given me directly uncomfortable questions, and at times, and we've tried to address those. So, I just want to say that we're all in glass houses, and it's really useful for us to hear when things are working and when things aren't working. And then I have a question from staff. Who has called in with the phone number ending in 6672? Is that is that Judge Crawford? Commissioner Similik?
I think that's a Madras number, isn't it? I think it's Commissioner Similink.
Oh yeah, it must be Commissioner Similik. He was having communication problems earlier. He had put that in the chat. So that would be my guess. And so Miguel, you're up. So we have on the agenda, and this is a required presentation for the board as the governance committee for the CCO, and this is an update on culturally and linguistically appropriate services.
Yes. So thank you so much, everybody, for having us again with this topic. It's our last presentation from related to class standards. So let's move along. Next slide, please. Yes. So the idea today is basically provide you updates about the health equity plan, and particularly about our focus area. In the health equity plan, our focus area number 4 is about class standards as an organizational framework. So yeah, let's jump on that. So just a reminder, our health equity plan is a 5-year plan centered on class standards. The entire health equity plan is around class standards. It's the framework that sustains that. 52 goals in the Pacific Source Health Equity Plan with eight focus areas. And to do that, to do the plan, we take care during last year of really get community feedback in all our regions. And we listen to providers, community members, and obviously collaborators in all areas, dental, behavioral, etc. So this health equity plan is focused at the CCO operational level. So we want to elevate the capacity we have to tackle the problems that the health equity poses to the entire system. Thank you. Next slide. Yeah, so our score was very good. We even think that it was the highest score compared in other regions. It was 59 of 62. And however, we have a recommendation. They want us to provide more regional content. on the next time. It's difficult to have regional content. At the moment, all our regions are similarly. So the program is similar to all of them, and we begin to discover those differences where eventually we will have differences by region. So next slide. Yeah, next slide. So about the class standards, just a brief reminder, what is the class standards? Culturally and linguistically appropriate services. They are divided into 3 sections. The first one is about governance, leadership, and workforce. The second one is about communication and language assistance. They're the name of culturally and linguistically appropriate services, but it's not the only point of the class standards. And the last one, super interesting, the last point of the 15 class standards is around engagement, continuous improvement, and accountability. And the assessment we are going to present you today, it totally fits into that last section. So we need to know what we are doing in order to prepare better for the future. Next slide. And please interrupt me any moment with questions. So in the past, we have presented the class standards to the board, to the CAC, to the CAP, and to other community members. We ask our boards to adopt the class standards as a framework. And the class standards are included now as a framework for the health equity plan. And the more important, in the past, it was just me working on health equity, and now we have an entire super mighty team that is dedicated to advance in every region, in every 4 regions. So next slide. So we did an assessment. The assessment was an interesting exercise because we wanted something that could capture really, it was an internal assessment. So what we have, where are our capacity? Do we have the values? Do we have the structure? Do we have the policies? Do we have the process to advance diversity, equity, and inclusion? And we made an assessment. We create an assessment. I couldn't find any assessment dedicated to class standards. So what I did is to mix the mayor for one part, the HERSA, and other assessments that were related to either diversity, equity, and inclusion, or social determinants of health, and focus on really try to find where we were advancing diversity, equity, and inclusion, and what was needed. That was the focus. So at the level of our values, do we really have, are we attuned with this idea, or what we need to make a stronger decisions around this? Do we have the structure? Super important. Do we have the policies to support the changes we want to create? And do we have the processes that are needed to advance that? So that was the focus. 72 questions in total. We create an internal group, Pacific Source Internal, where we identified all the big players inside our company. And we launched this assessment for several weeks. And these are the results. So the results is that we have many strengths in the 3 areas. So governance, leadership, and workforce being the first one. We have a strong support from our leadership. We have structures already, resources like my job and other people that are doing that, accountable individuals, etc. We have a lot already, but we found many other areas. And this is just a selection of these areas because the assessment included 72 questions, as I told you. But the ones that we are already working on to advance, and some of them have good advances, is around policy, for instance, policy for board, recruitment, diverse policies that you have there. The most interesting for me of these ones is this idea that maybe we can integrate equity and cultural responsibility into the job descriptions. That will be something fantastic that will really help us to advance because of the role that the leadership has to really determine where do we want to move. So that's something we want to do. Next slide. And I'm sorry, I didn't took the time. How I'm doing in time? I'm okay? Okay.
You know, Miguel, we're way ahead of time, so you're cruising.
Perfect. So in the next section, it's around communication and language assistance. So we found that we have already some strong policies to do that. However, we reviewed the entire policies that were related to language access and communication services, and we updated them. So we update the contracts. We don't still have the capacity to create the incentives to create a better system to support our providers that want to offer this, but at least we did the changes in the contracts. So the new contracts have already these suggestions or limitations about that they really need to offer support language to the members. So what are we trying? I'm sorry, my son changed the heat in this room and I didn't notice, and now I'm suffering. It was super high a few moments ago. I'm sorry. I didn't notice that at the beginning. So what we have to explore, we want to explore training for the staff that is facing members, training about how to distinguish when is needed to use interpretation services, for example, and how to get that. We have changed a lot. We are trying to make changes and already make some changes around the policies that we have for that. For instance, how to measure the efficacy of our translations, because we offer translations, but sometimes the efficacy is a different level, right? So even if it's translated and it's made by a professional translator, that doesn't mean that the message is well received by the members. So we need the support of the members to really help us. And we are designing a program next year where we are gonna bring a few translations with our community members. The Latino community will help us to see if the language is well translated, but is it culturally appropriate so the members can really understand what is there. And so we want that advice and eventually bring this advice to the person that has created the document as a learning process, and eventually to our translators to support this continuous improvement process. So we have that. We want to we enhance the policy to ensure that providers are using qualified or certified interpreters. We know that's a problem because the problem is that we need to have the number of certified or qualified interpreters. So most of the problems we found are complex problems that are linked with other ones, like in this case, related to workforce diversity. So we are also making efforts to try to support the development of workforce diversity, to have better, more well-trained, certified, qualified interpreters that are available. This is a complex situation because if we measure utilization only, the numbers that we have are very low in terms of interpretation. However, for our communities, they don't want to know about interpretation. They want to know about availability. So are there interpreters? Are there providers when I need it? It's not how much I use them, right? But do they exist? And the answer in many cases is that we are behind in those areas. So all these situations that we are trying to solve have different ramifications. And this assessment was fantastic to give us a tangible field of topics. And by the way, these, what I bring to you from these 72 questions is what our internal committee choose as as the most important to work. And from these, we create a few projects. It was like one project for each category to advance next year. So the task we have ahead is it's huge. But at least we have a tool. It's the first time, so we are so happy with this. The last part, next slide, please. Yeah, the last part about engagement and continuous improvement and accountability. This is the part that I really like the most around the class standards, because we always focus on the language and cultural aspect. But this is totally a challenge because it's about how do we work together with the communities to advance what we want to do. And we found that we already have many things, like the health equity plan. Fantastic, that's the first one we have that. And we are so happy and proud of that. We are conducting for the first time an assessment about our capacity to advance diversity, equity, and inclusion. We have now and collecting more and better demographic data. And we know that we have a problem with demographics because we depend on what is self-described on the applications of OHA. And so it's really a challenge to how to integrate what we know it exists to what we have in paper. It's a challenge, but we are working on that. And we are doing great efforts on that. So reporting back, that's another thing that is new for us, like this report I'm doing. Disaggregating information according to RealD, and it's a challenge for us, and we are advancing a lot on that. And the community advisory committees that we have, in this case only for Medicaid. So that's our strength. We found that we have a lot to work with at this level of involvement and accountability, but we have a lot to explore. So we know that even if we identified things that need to move, that is not a constant process. So we need to create more a culture of assessing what are the needs and use that to make our plans. And we create we want to create a policy that ensures that we are using this information to remake our organization plans and according to taking into account the linguistic needs of our communities. That's a big part. Obviously, in the same idea, taking into account the information that we have around RealD and LGBTQ information, right? And so there is a lot about policies on this explore area, but really our focus is not just the policies, because sometimes the policies is just a declaration in the paper, but when we create the assessment, we make sure that together with identifying a policy, we were able to identify what was needed to create a process to move ahead, but not just the paper. Grievance and appeals was a big topic of that. That's the last one. And we are even trying to, similar to what we are doing with the translation documents, to create some effort to go to the community partners and identify what is needed, how can we better, and how can we improve the quality of the entire process of grievance and appeals, because we know that minority groups are less prone to come to us with the grievance and appeals, and we don't have the feedback, the good feedback to improve our services. And that's a cultural, historical situation, and we are working with a project to do that. So there are 72. There are too many to share with you, but at least my idea was to try to share some of them with you, and then I'm open to questions and discussion, of course.
So Miguel, that was a very warm presentation on a hot topic. And you know, you've been sweating it for sure. Any questions or comments from the board?
Hey, Rick, I just have to say, I appreciate your goofy humor, man. It's funny. Miguel, so you said you've been scored 59 out of 62. You received that score. Does OHA evaluate you? Do you evaluate yourself as specific source, as the CCO? That's the first question. The second question is, what are the 3 points that you didn't get a good score on? And I apologize for focusing on the negative, but I'm curious.
Yeah, so short answer is I don't know. And those are the numbers I got from my boss, so I don't know the details or where was it. But I share with you that one of the important recommendations from OHA, and maybe that was the case where we lost those points, was that they want to see more content, more regional content. So they want to know more, okay, you have a region in your hands, so do you have something that is specific to you? So that's something that we are trying to think ahead for the next time. Yeah.
And the first question was, who comes up with that score? Who evaluates your
Oh,
play,
thank you.
your
So
progress?
it's, yeah, when we finish the they evaluate our report, OHA, and they have so it's they have a format. So we receive a format, we send that, and OHA give us that that numbers. I don't know if Tricia knows more about how do they qualify it, or maybe Dan. I'm sorry, but I have no idea. I just have the number.
Yeah, it's scored through the Office of Equity and Inclusion at Oregon Health Authority. And in terms of their framework, I'd have to get more information and detail around that. But the group that is doing the scoring is OEI at OHA.
Thank you, Rebecca.
Megan.
Hi, Miguel Angel. My comments maybe a teensy bit tangential, but I do appreciate the last slide and the focus on collecting the real D data, because I do think that's a gap in the region as far as being able to report on different indicators, whether they're quality indicator, utilization indicators, by those different categories, so we can see where there might be some disparities to put in intervention. So while not completely related to the reason that you're here today, I think that can be like an additive benefit for how we start to organize and look at data and have interventions going forward.
Yeah, so that's always a topic, right? Because it's a weakness we have in the system, the capacity to really see the topics according to real data. The problem is that the information that we have comes from OHA, and what they have is what the members declare themselves. And we know that there are many topics that influence these self-declarations. And the ones that we are more interested are the most sensitive, like language, for instance. So many people doesn't want to say that they have language needs because they feel they are afraid, oh, maybe that will qualify me bad for, or I will not qualify for health Medicaid if I say that I have a need, an extra need. So this is a cultural, historical thing. We know that the numbers we have don't reflect reality. For instance, just a number in my memory, we know that in Central Oregon we have around 9 or between 9 and 10% of Spanish-speaking population. But when you see the needs around interpretation services, you will see a number around 4%. So that gap that between the population we know that exists and the number we collect, we know that we cannot reflect. So it's a big topic, Megan.
So Miguel, I think you did say something about it's more than language. And I just, to relay a story, within my own staff, we have a Latino residential program in Madras, and most of the staff there grew up in other countries than the US. And so we can supply all sorts of translation. We can, when we have our health insurance annual meeting to go over our health insurance benefit, what's fascinating is folks who grew up in other countries, their assumptions about the healthcare system and how benefits are provided are very, very different than our assumptions. And so much of the problem isn't about language. It's about just understanding how the system works. And then we already have an impossibly complex healthcare system. And even if you're a highly educated person who works in the healthcare industry and who can be quite assertive, I'm still have to go to my HR department and say, well, how does this work? And so if you don't have all those advantages, then it can be very, very murky for folks, even if the language stuff is all translated well. So really good point and really good work that you're doing.
And that is super difficult to assess, right? We can't put numbers and to create goals, specific goals around that, because that aspect of culture, it's really based a lot. When you begin to see that, it's because you have built relations based on trust, and that information that we know that the hospitals and clinics, they collect a lot of that, is not coming to Pacific Source, for instance. We haven't found the right way to share this information, because in the clinics, they have the trust, the members have the trust, and they know and they understand each other's, and they see the same doctor, and they collect a lot of information. It's a challenge for us to try how to find a way to mix that with the one that we have to make a better use and take better decisions, assistant level decisions. So thank you, Rick, for being so sensitive to that aspect of culture that is so subtle and untangible. Thank you.
Anybody else?
Yeah, Miguel, going back to the health equity plan score, which we did very well. You did very well. Congratulations. Do we know how that compares to other CCO regions?
I have the feeling that at some level in my company, they may know. I don't know. All I know is that we qualified very, very high, possibly one or the highest among the other regions in the States, yes. And it makes sense because our company has been working on class standards for years. So when we received this format, because the format it's based on the class standards, for us was a logic match. So we have a lot of work already done during past years that we ourselves tried to advance class standards, I think, for 4 or 5 years already. So it was a good match. And we have great partners. So
we have representatives on other CCO boards, and I'm not aware that that there's been a report out on them. So I am kind of curious where where would you go to get the information on how the various CCO regions would stack up?
Rebecca, would you know that?
Yeah, I'm actually looking right now to see what's public and what's not public related to the health equity plan. So let me get back to the board on that and see what's publicly available, if there's planned comparisons, and I'll send that to Donna and team to send out to the board once I find that information.
Yeah, so the comparison information would help us understand that score. Okay, any other questions or comments?
Let me go.
Yes, Brad.
So the need for more regional feedback, what exactly are we talking about there? Feedback from consumers, feedback from, what are you talking about?
Yeah, so there are two levels of feedback, right? One is the first level is what we are doing, what is needed, how do you, how is impacting the services in general. That's one level that we think we can achieve in the near future. So as an example, the two strategies that I shared with you already, to go and assess the quality of our translations, and also to learn about what is needed to get a better culture around grievance and appeals. So that's an example of one level of feedback. The really challenging one is the ability to go further and create programs in collaboration with members and with community partners. That's for what I sensing, and from the assessment we do, we still don't have all the tools, the procedures to really work together with the communities. We are still on a phase where we are designing the processes and the services and try to assess that. The real challenge will be to do it together. And I don't see how we can get there easy. There are many challenges there. Just to give you an example. So how many BIPOC people I see in this screen, right? So if we don't have the BIPOC people talking and pushing and bringing the topics that is important for them, how can we talk about collaboration really? It's difficult because we don't have those voices. But those voices need to be even created, because we do have leaders, but not that many, right? But so we need to invest in that. Nothing is going to happen just because. We need to really make investments and medium, long term. And that is applied. So I'm thinking on workforce diversity. Workforce diversity is not just having community health workers or interpreters. Workforce diversity, what we hear from the community is that they want more people like them at every level of the system. And that is a complex situation. Did I answer your question, Brad?
Yeah, I think so. Whoops. I'm thinking back to, when putting on my Latino Community Association hat, when we partnered with Pacific Source to do, the workshop, the community feedback, workshop there at your building, and provided childcare and did all the outreach and, helped get people there, provided food, doing more of that, but then also at that type of a gathering, asking the people there, would they be interested in, serving on some, committees, on boards, and, it may or may not work. But I think we need to do more of that and take advantage of those moments to recruit membership on leadership, committees and boards. So thanks.
Thank you.
Okay. Thank you, Miguel. That was a good discussion and very useful. Thank you very much.
Thank you all. Thank you for having me here.
Donna Mills, you have a couple of topics.
I do. Rebecca's going to put up a visual for us. I just wanted to bring to the board today that the work groups have been successful in investing. We were required this particular year to invest $2.5 million into the community, and we have more than met our goal. So thank you to the RIP work groups. I know how seriously the community takes their responsibility in this space, and they do not rubber stamp grants. They really do take quite a rigorous view and use the matrix that the staff has created and provided and vetted with them. Thank you to the staff. They're amazing as well. And for Rebecca and continuing to track these grants. But I just wanted to give you a visual about where that funding has been spent. I don't think there'd be any surprises in the fact that stable housing has actually spent the most. But the reality here, and to the point of making sure the board is aware of, we are making our commitments. We actually have until March 31st of 2022 to have these funds spent, and they have been spent. And I am really happy because then they get in the right year on the P&L, and I don't have to worry about it. We are at 2.9. The October financials only say 2.6 because of the difference in the month that they were distributed. And we go forward next year with already a couple of fairly large grants that we're going to be able to book and get a good start on 2022. So thank you so much to the RIP work groups. Are there any questions about that from the board before I go on to my next topic?
Donna, this is Linda.
Yes, ma'am.
It seems to me, in terms of feeding back to our community, in addition to the Health Council, but primarily our external community and partners that we work with, do we have planned a press release or some piece of something that would sort of describe at a broad sense where our priorities are, and then maybe diving deep on one such as stable housing, not at the granular level, but what sorts of projects have we been funding to support the stable housing initiative so that people know where their dollars are going?
Yeah, I would say right now, Linda, we are primarily using our website, but I would also add that for the most part, once we have made the investment, the grantee is usually the one that puts the press release out. Again, because these are such large dollars, sometimes the story, we can't tell the whole story in a snippet. So I actually last night caught, and of course, clearly I hear Central Oregon Health Council on the news and I'm like, oh my gosh, but they were touting a grant that we had given to COCC. And so sometimes it comes up in that. We have gone back and forth on this about, putting that press release out every time, or even in a, to your point, in a more summarized and then maybe highlighting one. And we keep coming back to it, just ends up being so convoluted. So I'd like to have further conversation about that, if you would, offline, to help that along. Thank you for that recommendation. I know that we get stuck between the tension of tooting our own horn and the community not knowing what we're doing. But I think that, interestingly, through COVID, we made a lot of friends during COVID and have continued to, because of the mini grant program, of course, that we sunset in March. But that really introduced a lot of new folks to the Health Council. So thanks for that question. Anyone else? Okay, my other non-agenda item that I want to mention, relative to the combined meeting in September and the priorities that were set for the board and CAC, I have it here. I did not give it to my projection file person. But the first two priorities that you all had come up with were joint meetings every 3 to 6 months with meaningful, purposeful agenda and dialogue, and CAC members' own patient stories at monthly board meetings and focusing on reality. Well, we clearly have been focusing on reality today, have we not? So I wanted to mention that, although not ideal, for our very first board and CAC meeting, we're actually going to take a portion of the board meeting, which we will adjourn the general board meeting and then open our CAC board meeting on January 13th. And we don't have your questions yet. We're still noodling on those, but it really will give an opportunity for that work to be continued. And if you hadn't seen, I did send out a save the date earlier. So for board members, this is already on your calendar and you're already committed to that time. So we know that you'll be there. We had hoped to do this in person. And frankly, after much thought and consideration and actually reaching out to a few trusted partners, have chosen to remain virtual. So we're sad because we really want to see you all in person and very soon, but it's just not time yet and it's just not safe. So we're going to err on the side of caution as we typically do. So any questions about that, let me know, but I just wanted to say that out loud in case you didn't get to read that in your email anytime soon. And then I wanted to thank Rick for his work as our illustrious board chair and funny. I will add that as well, Brad. He is funny. I know that we couldn't have possibly caused all that gray hair. And that I just want to thank you for your service, Rick. We really appreciate it. I'm done for the day.
Okay, well, I appreciate the opportunity to be your board chair for 2 years and basically keep the seat warm for Tammy as she had her interregnum. And I would comment that during the board meeting, I was able to block Tammy's phone number on my phone. So block sender for sure. Good luck. See you later. No. So, and I will continue on the board. But so thank you very much. And I think Tammy will resume her. She was, for new people, she was the founding board member, board chair, and was a shepherd us for a very long time. So very much appreciate her following what we're doing. Okay. Tammy,
Well,
you want to say
thank
anything?
you. Well, I just wanted to say thank you to you, Rick, and I hope that you don't, leave us without your humor in the meetings, and it offers a bit of levity. And certainly, I'll be tapping you. And as I mentioned earlier, it's a joint effort in guiding this group forward. So really, it's facilitating the meetings, but it's all of us that do the work. So thank you for handing the gavel. I look forward to engaging a little differently. But Rick, it's great to work with you. So I'm excited that we're going to be partners in crime. Linda, I look forward to getting into a little trouble with you too. So always look forward to an opportunity to spend more time with you. And I think next year is going to be a great year. So thank you everyone for your trust in me too.
And thanks to both of you. It's been wonderful to be here and to be able to work with you guys and with the whole board. And so I'm just honored to be able to say adios for just 1 second, Rick. You're not off board at all. And I look forward to seeing you and working with you, Tammy.
Wonderful.
Thanks a lot, Rick.
Okay. We are done. Thank you very much.